Would like to welcome everyone to the final day of the webinar series marking the Myopia Awareness Week. And thanks to everyone who's been joining from day one. We really appreciate. We're also grateful to our sponsors, the Lens Ophthalmics and BioLens Incorporated, who have been there right from the start. BioLens are manufacturers of specialty contact lenses, orthokeratology, scleral lenses, custom toric lenses, pediatric aphakic lenses. They do all things contact lenses, and we're very grateful for the sponsorship. So on this last day, we're going to be talking about the contact lens options for myopia management. This is something that I am passionate about, seeing that this is my area of specialty and an area I have researched in and involved in clinically as well. And I am trained also in this area. I'm the head of corneal contact lens, just as a way of disclosure, I'm the head of the corneal contact lens unit and the myopia management services at the Lens Ophthalmics. And I'm a speaker and I've received travel grant and honorarium from BioLens Incorporated. We all know what myopia is, and I'm going to skip that slide. And we know that over the past week, we've looked at several tests that we can do when it comes to myopia management. We've talked heavily on refraction, especially cycloplegic refraction. We've talked about keratometry and corneal topography, and I'm going to dwell a bit more here. First of all, we've looked at keratometry and corneal topography as a tool for us to rule out secondary or refractive myopia, not true axial myopia. However, in clinical practice, if you're going to do myopia management and you decide to take up the contact lens options for myopia management, you would need to have a keratometer or a corneal topographer. If you're interested in orthokeratology, having a corneal topographer is definitely compulsory, not just to rule out keratoconus, but also in the prescription of the orthokeratology lens that you are going to give at the end of the day, and also the success or troubleshoot issues associated with orthokeratology. We've also talked about the need for dilated fundus examination. Biometry is extremely important because it's one parameter that we need to monitor when we look at myopia management. And then binocular vision is also important as well. Now, yesterday we did talk about peripheral refraction, and Swapnil really elaborated on how peripheral refraction can influence eye growth, can influence myopia etiology and myopia progression as well. The traditional thing we do is give single vision spectacles or contact lenses that gives clear vision centrally, but there is still some amount of uncorrected hyperopia or hyperopic defocus in the periphery relative to the central retina. And that's what we refer to as relative peripheral hyperopic defocus. Yesterday, Swapnil did mention a study that is still currently ongoing in my practice and in two other centers in Nigeria, where we're trying to collect data for peripheral refraction for Nigerian or African school-aged children, because we currently do not have a robust data for that. And as he did mention yesterday, we're seeing that in individuals who are myopic, as you can see on this black arrow, or this black line in the graph rather, we see that they tend to have more peripheral hyperopic defocus compared to the hyperopes or non-myopes represented in the red line, who tend to have peripheral myopic defocus. And the basis for this hyperopic defocus that we see here, you can see on the y-axis, you see for the myopes, this is all towards the plus side, but we see some asymmetry. It seems that on the temporal side, there is less peripheral hyperopia compared to the nasal side. But however, we do see peripheral hyperopia, both nasally and temporally. in the eyes of myopic individuals. Now, the basis of this is why we have optical interventions that use these lenses, bifocal lenses, myopic defocus lenses like Stellest, DIMS lens, the MyoCare from Zeiss, plus power in the periphery to correct this peripheral hyperopic defocus. Now, this same theory applies to the contact lens options. But before we begin to dive into the contact lens options, one very important thing that we need to talk about, as I always mention, is giving single vision spectacles or single vision contact lenses is not myopia management. You're giving clear vision, but that's not controlling myopia. Now, the first option we're going to look at is the center distance multifocal contact lenses. Now, multifocal contact lenses are not new to optometry. Multifocal lenses have been existing for many years. Excuse me. And typically we've used these lenses for correction. But the idea of using multifocal contact lenses for myopia control took had a real push after the bifocal lenses in nearsighted. So this was a large clinical trial that had looked at using center distance multifocal contact lenses for myopia management. Children included in this study were between the ages of about 6 to about 12. And we saw that in this study, there was a Blink 1 study, that's the bifocal lenses in nearsighted kids, stands for Blink, or is what Blink is. So there was the Blink 1 study, which established the efficacy of using bifocal lenses in nearsighted kids. And then there was the Blink 2 trial, which looked at which ad will be optimal for myopia control. And what the study found was children who were in the high ad group, who used an ad of plus 2.5, had better myopia control efficacy compared to children in the low ad group. Now, some of the indications for us to use multifocal contact lenses will be a fast progressor, for example. When you have anisometropia, for example, today I had a referral for a kid who is a minus 13.5 in one eye and a very low myopia in the other eye. And obviously, because of the huge difference in the refractive error, there was already amblyopia in the high myopic eye. There was grade category 2 myopic maculopathy. And thing to do, or the traditional thing that would be done would be to give single vision spectacles or single vision, well, spectacles mostly, and undercorrect the very high myopic eye. But the problem with undercorrection, we know, is it's myopogenic. So for cases where you have significant anisometropia, contact lenses will be the way to go. But also, there is actually the barrier regarding contact lenses are barriers that we put ourselves there. I'm going to digress a bit from what's on the slide and just address this, because a lot of times as practitioners, we are the ones who put that uneducated fear in the patient. I call it uneducated because it's actually not founded in science, as we will see during the course of this presentation. But so long as the kid is above the age of 6, and you're able to teach the child, also teach the parent as well to insert and remove, what we actually see is, in terms of contact lens safety, as I'll show some papers as we go on, contact lenses are safer in children compared to adults, and it's very well documented in research. That's why that fear about using contact lenses in kids actually does not come from science. It comes from personal bias or things that you think may happen, but not necessarily. Important thing to take away from the Blink 2 study or the Blink 2 trial was that children who had used the high ad progressed way less after 3 years compared to those who used the medium ad or the single vision contact lenses. We see that in the high ad group, after 3 years, myopia progression was 0.6 diopters. Clinically, that would be like 0.5 diopters. And compared to the low ad group, which was plus 1.5 ad, we see that the myopia progressed by about minus 0.8 diopters, or about almost 1 diopters, and the single vision group similarly. Now, it's very important to not confuse center distance multifocal contact lenses with center near multifocal contact lenses. There are not too many brands of companies that offer center distance multifocal lenses. The brand used in the Blink 2 trial and the Blink 1 trial as well was the Biofinity D lens from Cooper Vision. Now, the Biofinity multifocal D lens is a center distance multifocal contact lens, which causes what we term positive spherical aberration. So what that means is the distance power is at the center, and around it you have a gradual increase in plus power or a gradual decrease in minus power that eventually leads to the full add within the pupil still. Now, we know that multifocal contact lenses work based on the principle of simultaneous vision. But when we're trying to correct presbyopia, we use the center near multifocal contact lens. So the center near multifocal contact lens has the add power at the center, and you have distance power around it. Now, this would tend to give better near vision, with distance vision slightly decreased. However, you could always adjust the size of the add portion in relation to the pupil size to alter the defocus the patient experiences at far. Now, the center near multifocal contact lens used for presbyopia works based on the principle of negative spherical aberration. So keep in mind, in myopia management, we're trying to address peripheral hyperopic defocus. So it makes no sense having that add centrally while you're having the distance portion around it, because then you're not getting that correction of the peripheral hyperopic defocus in the periphery of the retina. Now, with center distance multifocal lenses, distance power is at the center, and around it you have that plus power. Now, what the Blink 2 trial recommends is use that plus power of use the add power rather of plus 2.5, which will correct the peripheral hyperopic defocus in the periphery of the retina, and that's what prevents axial elongation. Now, in January this year, the long-term outcomes of the Blink study was published. So these children were followed up for 3 years wearing multifocal contact lenses of low add and high add. And after 3 years, the lenses were stopped and the children were followed for an additional couple of years. And what was seen was that despite stopping the center distance multifocal contact lenses, the 2.5 diopter always had lower myopia and shorter axial length compared to the single vision group or the low add group. So what that shows is, so long as you decide to use center distance multifocal contact lenses for myopia management in kids, you should be aiming for the high add lenses. Also, what the group showed was that, again, remember the goal of myopia management is to slow down that progression or stop the progression as much as possible. But also, we need to also remember that there is a physiologic axial length growth, and that physiologic axial length growth also has some amount of change in the refraction that occurs. But it has to follow either the physiologic pattern or less for us to say that this treatment is efficacious. And we know that on the average for children, axial length would grow about 0.2 mm or less per year. Now, after stopping the center distance multifocal lenses in children in the Blink 2 trial, those who were in the high add group, what was noticed was that the axial length started to grow at a normal rate, actually by approximately 0.03 millimeters per year. So it shows you there was almost no change in axial length, even after stopping the center distance multifocal contact lenses. And the refractive error was changing at a rate of 0.17 diopters per year, which is not clinically significant because we know it has to be up to 0.25 diopters for us to say it's clinically significant. Now, the takeaway from this is the effect of, and this is something I have seen in my practice as well, where we've had kids on center distance multifocal contact lenses for maybe 3, 4, 5 years, and then we stop the multifocal contact lenses, and maybe the child wants to wear colored contact lenses or just wear plain clear lenses, which are cheaper. or switch back to spectacle options or alternate between the multifocal contact lenses, we see that the myopia never progresses, steadily never progresses. In fact, I did have a patient who was about -5 at the time we had started, and in the other eye was about plus 0.5. So we were doing, we started with center distance multifocal contact lenses in the -5 eye, and this was some years ago. And the -5 till date is still -5, and we focused on that eye. Meanwhile, the the plus 0.5 eye and this was before pre-myopia became a thing, but the plus 0.5 eye started to progress as well. And till date, we are doing myopia control. We've started myopia control on that eye, but the -5 eye has remained -5, even after the child occasionally stopped wearing multifocal contact lenses in that eye. Now, what this means is that so long as the child has done the 3-year treatment period with interventions and you stop it, so long as the intervention being used is center distance multifocal contact lenses, there is a high likelihood that the myopia control effect induced by center distance multifocal contact lenses remains despite discontinuation of the treatment. So what the recommendation from the Blink group was that when using center distance multifocal contact lenses as a method for myopia management, it's important to follow up the patients up until the point they show no more signs of progression. You can then discontinue the center distance multifocal contact lenses, and the effect of the myopia control will remain despite stopping those contact lenses. The next lens we'll look at is the lens option we'll look at is the dual focus contact lens. Now, this is a daily disposable contact lens. This is marketed, this is produced or manufactured by Cooper Vision as well. In a way, you can think of it similar to the center distance multifocal contact lens, but this has alternating rings of +2 diopters in them. Keep in mind, the Blink 2 trial used the plus at 2.5 center distance multifocal contact lens. The dual focus contact lens, uses an alternating ring. So you have central distance power with alternating powers of +2 diopters around it. And well, this lens did show very good myopia control, similar in terms of efficacy to the multifocal contact lens, but it does have an advantage. It's a daily disposable lens, whereas this is a monthly, the Biofinity D multifocal lens used in the Blink study is a monthly disposable lens. So obviously better hygiene, better ease of use because it's a daily disposable lens, but obviously more expensive. It does require a bit more time in terms of adaptation to get used to the optics, but it's something that's really good when used. Another issue with this is the range is limited. For example, with center distance multifocal lenses, I currently use the lenses from BioLens Incorporated for my patients. And because it's a custom contact lens company, I can get whatever power I want. So even if I wanted to order a -10 or a -12 or a -13 or 14 or 15 with an add of 2.5 diopters, it's available to me. Whereas with the dual focus contact lens option, you have a limited range of powers that you can order. And also astigmatism tends to become an issue because you have to do spherical equivalent with this. But meanwhile, with the center distance multifocal contact lenses, you can actually get options in toric options. So you could have a center distance toric multifocal contact lens done. Now, there is also the extended depth of focus. Now, this uses what we call Cartesian optics. So basically, it's similar in terms of ideology to a center distance multifocal contact lens. However, the rate of progression from the distance power at the central part of the lens and the portion where you have the full add is very rapid. Now, that small area where you have the distance power at the center of the pupil with a very rapid increase in plus power surrounding that central distance power gives a pinhole effect, which extends the depth of focus. So this lens was actually designed for presbyopia, but we've also seen that it has very good efficacy when it comes to myopia management. Studies done in Elvi Prasada Institute in the myopia research lab showed that in children that these lenses were fitted for, myopia progression was about 0.2 diopters after 1 year, compared to control group that had approximately 0.5 diopter progression. So that there you see about 50% control. And then in terms of axial length, it was also about half. Progression of increase in axial length of about 0.1 mm compared to 0.22 mm in the control group. Now, another advantage for this option of myopia control is it is a daily disposable contact lens. It's a bit more affordable, and you get 32 lenses in a pack as against 30 lenses or 28 lenses that you might get with other options. Now, let's talk about orthokeratology. Now, orthokeratology is a very interesting and unique thing. And I mean, you could almost tell that I'm excited when I talk about orthokeratology. It's one of the, I mean, I currently have over maybe, this is just me eyeballing off my head, over 60 individuals wearing orthokeratology lenses. However, 90% of those are kids. And orthokeratology initially was designed to be an alternative to refractive surgery. However, we began to notice that children who were fit with orthokeratology or young adults who were fit with orthokeratology were not showing any signs of myopia progression, or if at all, very minimal. And that idea evolved into better designs for orthokeratology for myopia control, not just for vision control, vision correction, and also a lot of other studies into myopia management and understanding the etiology of myopia management as well. Now, orthokeratology basically involves using rigid gas permeable contact lenses to gently reshape the cornea and change the corneal curvature, change the corneal shape, change the corneal eccentricity or asphericity to give clear vision throughout the day without having to use spectacles or contact lenses, and also control myopia. Now, would say in the early days of orthokeratology, we used to think that it was the manual compression or pressing or bending of the cornea that actually led to the orthokeratology effect. So the ideology would be if somebody has, say, -4 diopters of myopia, and the flat keratometry reading is, say, 48 diopters, and I wanted to correct 4 diopters of myopia. Sorry, excuse me, 1 minute. Okay. Yeah, let's continue. In the meantime, if you have questions, contributions, please leave them in the comment section, and then I'll take them at the end of the lecture. So as I was saying, if you think back to what we used to think about before, and I was giving an example. If you have a cornea of a patient who has -4 diopter of myopia, and we're trying to correct that with orthokeratology, and the steep or the flat keratometry reading, let's assume that's 48 diopters. The crude ideology would be for me to fit a lens that is 4 diopters flatter than the flat keratometry reading to alter the cornea shape and give me plano. Now, the idea was that we were bending the cornea, but what you're actually doing is changing fluid redistribution on the epithelium of the cornea. And we have evidence for this because there are studies that have shown with anterior segment OCT, changes in epithelial thickness in children or individuals wearing orthokeratology lenses. And what we have always seen is the central epithelium becomes thin, so it becomes thin, while the mid-peripheral portion of the epithelium becomes thicker. So in a way, it's sort of creating a minus lens over the cornea to correct that hyperopia, correct that myopia. Now, what the lens does is actually gently turns the cornea from its natural prolate state to an oblate state. So flatter in the center, slightly steeper in the periphery. Now, that mid-periphery steepening is what brings about the peripheral correction of hyperopia. So what you see here, for example, is corneal topography for one of my patients who have done orthokeratology on. And just to give you an interpret corneal topography results, cooler colors indicate flat areas, warmer colors indicate steep areas. So you see here, we've made this cornea flatter in the central part, but steeper in the mid-periphery part. And this gives sort of a bullseye pattern. Now, this is what an ideal ortho-K final fit should, final corneal topography should look like. Now, when you've done orthokeratology, studies show that the amount of plus power that you induce in the mid-periphery is typically directly proportional to the amount of myopia you're trying to correct. And that's one of the reasons why ortho-K gives very fantastic myopia control. So if I was doing orthokeratology for a -4 myop, I will expect to be getting about +4 diopters in the mid-periphery to correct the peripheral hyperopic defocus in the retina. Now, this is an ortho-K lens, and I'll just walk you through what this sort of what we're looking at when we're talking about ortho-K. Now, this is a picture of a kid wearing ortho-K lens in my practice, and you see at the central part we have the pupil. We call this part the treatment zone. Around that, we have the we call this the reverse zone or the return zone depth of the lens, and this portion here is what is responsible for this mid-peripheral steepening. Now we have the alignment zone, which keeps the lens well centered on the cornea to improve the myopia correction and also give better vision or better treatment. And then we have the peripheral zone, which allows tear exchange, prevents hypoxia. Orthokeratology lenses, keep in mind, are not worn during the daytime. They're rigid lenses, yes, but they are very comfortable because they do not move typically like your normal typical RGP, corneal RGP will be moving. So it has very minimal movement. The diameter is very, very much dependent on the horizontal visible iris diameter of the cornea. So you have a lens that sits very well on the cornea, very stable, minimal movement. The materials are made from very highly oxygen permeable materials, so you do not have the issues or worries about hypoxia or lens binding to the ocular surface or to the cornea when you fit properly. Now, another advantage is with orthokeratology lenses, whether you're wearing them or whether they are off your eyes, you have clear vision. So if the child's wearing the ortho-K lens and wakes up in the middle of the night, say to use the restroom or whatever, they still have clear vision on. When they take it off in the morning, they still have clear vision. So what the orthokeratology lens does is gently reshapes that prolate state of the cornea to an oblate state to correct the myopia, give clear vision. Typically, we aim for something close to +1. So with orthokeratology, we actually slightly move the patient to a hyperopic side. So the idea, we call that the Jensen compression factor. So we overcorrect rather with orthokeratology by about, say, 0.5 to 0.75. Now, what happens is if I have a 4 diopter myop and I've corrected them to about plus 0.75, we know that orthokeratology effect is temporary. Although I would say this, I have some patients who are able to use their orthokeratology lenses once at night and then go 3 days, have clear vision, and have to put it on the 3rd day. But this does not happen in every patient, and this is obviously not the recommended wearing style or schedule. But what we actually see is when the patient wakes up in the morning and they're about plus 0.75, by noontime, that effect starts to wear off and they go towards plus 0.5, plus 0.25 or plano towards the evening time. And by the time orthokeratology lens is wearing out when the child is probably becoming minus 0.25 again or minus 0.5, it's already time to go to bed and put on your orthokeratology lens. Whereas if we were just aiming for plano alone, The issue is by noontime, the child is probably minus 0.25 or minus 0.5. Again, I'm saying child, but autokeratology is done for adults as well, mostly for vision correction as an alternative to refractive surgery. But yeah, most times these days we're doing autokeratology more for kids than actually adults that the lenses were originally designed for. Now, for autokeratology, the idea is for vision correction, we usually would like a very wide treatment zone. However, for myopia control, we want the treatment zone slightly smaller, about 5.5 mm or about 6 mm in diameter. The reason is the closer we can bring this mid-peripheral stiffening close to the pupil, the better chance control that we're going to get at the end of the day. Obviously, for contact lens options, we would want the child to be above the age of 6 to fit orthokeratology. Kids, it's very easy to insert orthokeratology lenses because they're quite small. They're smaller than the HVID of the eye compared to soft contact lenses, which are larger than the HVID of the eye by about 2 mm. These are typically small, about 0.2 to 0.4 mm smaller than the HVID. It's easy to just put them in the eyes. Taking it off, it's also easy to do that. You could either use the finger method or you could use a plunger to take off the lens. I typically prefer to teach patients to use suction plungers to take off ortho-K lenses, just because I find that sometimes kids can be playful and they might bend the lenses and reduce the treatment efficacy that the lens will give. Now, the FDA, the US FDA recommends that we do an addition, a range rather, a power range correction of between minus 1.5 diopters to about with orthokeratology. However, we know that there is published evidence and large clinical experience with correcting higher variations of myopia. Personally, the upper limit I have corrected or managed is minus 8.5, that we've been able to get down to plus 0.5. However, I know some designs of my orthokeratology that and BioLens does that as well, that can be used for high myopia. And I have seen cases, I have colleagues who have done cases up to about 10 diopters of myopia. Now, also orthokeratology, the impact can be affected by astigmatism. So typically, if the cylindrical component of the refractor is higher than the spherical component, we tend not to prescribe orthokeratology lenses, mainly because the lenses do not center well on the eyes. They become rocky. However, newer companies like BioLens and companies that are involved in custom orthokeratology lenses that are designed based on the corneal topography can actually design toric orthokeratology lenses that have a variation in the elevation to compensate for that toricity of the cornea from the astigmatism. And even though, yes, typically we'll still advise if the cylindrical component of the refraction is more than the spherical component, we tend not to advise orthokeratology. But if you had a prescription, say about -6 with -2 cylinder or -2.5 cylinder with the rule, keep in mind with the rule astigmatism, that before will be considered a contraindication for orthokeratology because of the 2.5 cylinder, because the rule, the old rule was it has to be less than 1.75 diopters of with the rule astigmatism and less than 0.75 against the rule astigmatism for the lens to center well. But now with the rule astigmatism of about even 2.5 diopters or even slightly higher, can be managed with toric orthokeratology lenses. And it's only going to get better as our softwares and AI, and we have better imaging tools to measure corneal toricity and corneal shape and put that into a lens for orthokeratology correction. Now, once you've done orthokeratology for a patient, and let's say I have done a patient who's a -4 and the patient comes in for follow-up and patient is reading 20/20 unaided because now the patient is maybe plus 0.25 or plus 0.5 or maybe plano, let's say that, for example. If there are changes in refraction, I would likely not know because the orthokeratology lens has knocked down that myopia. However, the way that we judge myopia progression in a child or an individual who has had autokeratology done is by biometry. So this is why axial length measurement is very important. From studies, we see that in individuals wearing autokeratology lenses, we get about 50 to 60% myopia control, but this really depends on the design of autokeratology lens that you're looking at. Now, I did mention earlier that we're going to talk about that idea that contact lenses are not safe in children actually doesn't come from science. Now, in a systematic review that was done by McBullimore et al., this was in 2017, and this is published in Optometry and Vision Science, so you can go back and read about it. The most feared contact lens complication that we all worry about is microbial keratitis. That's an infection on the cornea which would manifest with an infiltrate, stromal edema, sometimes an epithelial defect. Again, that's something that we all scared about and all worried about. Now, in terms of contact lens complications, you have to separate the serious adverse events from the non-serious or non-clinically relevant adverse events. Now, things like corneal infiltrates, things like somatic corneal infiltrates, punctate stains, and things like that. While those are adverse events, we do not consider those serious adverse events. But however, things like infiltrative keratitis, microbial keratitis, epithelial defects, those are quite serious adverse events. Now, in this systematic review that involved 9 studies, when pulled together, representing 1,800 patient years of wearing contact lenses. Now, this was in kids who were between 7 to 19-year-olds. No case of microbial keratitis was reported. Now, I'd take another, that's switching the slides. In this second study, in a multi-center study that looked at 3,000 plus patients who were wearing contact lenses were found to be very safe in children between the ages of 8 years to 12 years. Again, no case of microbial keratitis was reported. And 13 to 17, which represented a very large proportion of children in that study, 15 children did have microbial keratitis, representing an incidence rate of 0.15%. So what that means is if I were to fit contact lenses in 10,000 children between the ages of 13 to 17, 15 out of 10,000 developed, may develop or at risk of developing microbial keratitis. And again, if we go back and look at this data, now you would tend to see that even from the previous study I mentioned, the contact lenses seems to be safer at a younger age. Now, there are several reasons for this. It's not just an incidental finding. Children have sort of heightened ability to contact lenses, actually. Secondly, children at that young age tend to listen to follow certain routine. So you would often find if you have a kid who maybe every day you give them a syrup and they are used to you giving that syrup, and it's time for you to give that syrup and you forget, they'll come remind you it's time for my syrup. If it's time for them to wear their contact lenses or remove the contact lenses or clean the contact lenses, or you've missed one step in the cleaning routine, they remind you you've done something. It's typically when they start becoming teenagers, going towards the adult stage, that's when they start to behave like the rest of us adults who sort of have a mind of our own and do the things that we want to do despite the rules somebody has given. And also, in some of these kids who are not able to do the insertion and removal themselves, or who even can't do it themselves, we advise parental supervision. So the parents are involved in making sure that they're inserting the lenses properly, removing the lenses when they're supposed to, cleaning the lenses properly, using the right solutions. So in terms of that supervision, you have parents involved. You have eager kids who understand what you're trying to do and who you explain these things to, and kids who you train to insert and remove, which we'll talk about later as we go on. Now, that idea that if I showed you the statistics for adults when it comes to adverse events for contact lenses, it's way worse because adults are the ones who tend not to listen, who tend to top off solution, who tend to sometimes, I've had patients refer to me with cornea issues where they are using saline to clean their lenses, or we're using old solution in the container to clean the lenses, or just using water to clean the lenses. Using non-prescribed solutions, maybe something they got at the beauty shop. You don't see kids doing those kind of things. So in terms of published literature and my clinical experience, contact lenses are actually safer in kids compared to adults. But we always have that fear, oh, it's a child. These are medical devices. Nobody's saying for you to prescribe contact lens to all the kids that you see. Obviously, as you've seen, there are indications for you to say, go for contact lenses or go for glasses, or go for orthokeratology. There are indications for that. However, when you decide when contact lenses are clearly indicated for a child, that fear should not be coming from you as a practitioner because this is a medical device. This is not something you're doing for cosmesis. This is not something that you're doing just to maybe improve something in the child. Children to enhance confidence in children. It's been shown to decrease that social anxiety because I've had kids who we've done ortho-K for -5, -6, -7, and there's always that joy because they are no longer associated with those thick glasses when they're in school. And trust me, they actually would make a huge referral base for you because when you have a child who's always known for her thick glasses and a parent comes in and says, oh, where are your glasses? And say, I don't wear them anymore. I'm now wearing orthokeratology lenses. But I bet you that's most of the way I get referrals for orthokeratology. Aside from practitioners, yes. But a lot of these referrals will come from parents and actually patients who you've done orthokeratology lenses for. Now, it's very important that we get parents involved with what you're doing. You need to discuss the parameters of what you've found when you do your myopia control evaluation. Explain why it's important to undergo myopia management. You're not trying to sell something or convince them about something so that you can just get quick cash. You're trying to actually treat a condition, which we now classify as a disease, and prevent further complications in future. So contact lenses are one of the tools in your arsenal for managing myopia or controlling myopia. Now, create a risk profile for each of the patients that you've seen. How much screen time do they have? How much time outdoors are they having? Is there family history of myopia? Is this child spending too much time on network or doing too much digital device? Is there high lack of accommodation? Is there near esophoria? Once you've created this risk profile for the child and you have clear-cut indications to go for contact lenses, such as anisometropia, continuous progression when you've used the other options, a very fast progressive myopia, a child who's actively involved in sports, for example, swimming, football. Those are children who, again, who you don't want having spectacles on at that time. And there is nothing wrong in having myopia control contact lenses and backup spectacle myopia control spectacle lenses. So on the days the child may be involved in sporting activities like football, basketball, or whatever, they are wearing their contact lenses. If the child is a child who's involved in swimming, obviously we do not advise that you swim in contact lenses. And this is where orthokeratology comes in. Because with orthokeratology, you're only putting it on when you're sleeping at night. So in the daytime, you have clear vision throughout the day. So the child can actively swim and have clear vision while they're doing so, and you're not inhibiting or hindering the quality of life of that child just because they have myopia. Discuss things about axial length, the change about axial length growth, impact in terms of myopia and the risk associated with it with parents, and make an educated decision that is best for the child, not just something that you're making out of your own fear. Now, I often find certain things that I do, I mean, people who've maybe worked with me or practiced with me would see that it's something that I repeat over and over. You have a kid who comes in and the child is all hyper and everything, and you're often looking to the parent to maybe control the child or something like that. Or you have a child who comes in and the parent is okay with the idea of contact lenses, but the child is not so sure. Speak to the child. Obviously, don't speak like you're speaking to an idiot. Actually, speak to the child and explain what you're doing. I find it very helpful having trial contact lenses in the clinic for two reasons. One, you can pick up the contact lens. I usually would give the trial lens to the child, they wash their hands, of course, and then place it on their finger, and they touch the contact lens and they realize, oh, it's soft actually. I'm like, yeah, it's soft. It's not going to harm you. And would you like to try them on? Some might say yes, some might say no. They say no, and then you explain, you want to find out what's the thing. Are you afraid of it? Do you think, and they might tell you they think it will hurt. I explain to them it would not hurt, and I try it in one eye first. And as soon as I put it, if you're not comfortable, I'll take it out. And they let you try this thing. Now, I often find this helpful, and this I borrowed from, this idea or this practice I borrowed from a paper I had read some years ago, but for the life of me, I couldn't find that paper while preparing this lecture. But what was done in that study was in a practice, they had two groups, the method was divided into two. You had one group where the practitioner was proactively speaking about contact lenses to patients and offering to give them trial contact lenses to wear to help them see the frames that they were selecting better. Now, what that study found was when the patients who were offered trial lenses to wear put those trial contact lenses on and selected their frames, just picture this in your head. You have maybe a -4 diopter myo who's used to when it's time for frame selection, I'm going to have blur vision when I put the glasses, the frame on from the frame stand. My vision will still be blurred because your correction is not in place and you're looking at the mirror, you're going really close to see if it's clear. But then you've put trial contact lenses on this patient, and then they pick up a frame and put it on, and they have that clear vision and they can appreciate the details of the frame. I bet you most times, I mean, and I say this regularly, what you would often find is the patient would ask, how much are these contact lenses? Or can I fix an appointment to schedule for contact lens evaluation? Now, these I also try with children for frame selection to ease that tension about contact lenses. And in the study I was referring to, about 46% of people who were proactively offered trial contact lenses to wear during selecting frames actually purchased the contact lenses. And half of those who did not purchase at that visit actually came back to purchase contact lenses later or made inquiries about contact lenses later on. So it's not just better healthcare management when it comes to myopia management. It's actually good business for you. And you might be alienating a part of your patient base if you're not offering these services as well. And it's okay if you do not have the expertise for this, so if you want to get trained for it, or you want to refer to a colleague who actually does this. Now, from the contact lens assessment in use study, it's been shown that children actually would take a bit longer to teach compared to teenagers when it comes to inserting and removing contact lenses. So have a dedicated room or a dedicated consulting room, what you would rearrange to be a teaching room to teach kids to insert and remove contact lenses once it's time. In my practice, would have a table in that room that has a mirror with tissue solutions, and you have a dedicated staff, maybe an intern, somebody who's experienced, and teach them how to insert and remove the contact lens. Be patient with them, spend time with them. It's okay to actually schedule visits to just for insertion and removal training. But once you have that one-on-one with kids and they start wearing contact lenses, you have patience for life because contact lens patients always require solutions. They're going to come back to you. They require backup spectacles. They're going to come back to you. Maybe they have issues with dryness or whatever. They're going to come back to you. So either way, it's a win-win for you when it comes to contact lenses. Now, for contact lenses for myopia management, it's important that you realize that, I mean, there are some changes in binocular vision and also when it comes to contrast sensitivity that you might notice. For example, we know ortho-K causes a slight exo shift, slight exophoria, which if the patient has adequate reserves is insignificant. But if the patient has near isophoria, ortho-K is great because it will cause that exo shift or outward movement of the eyes that would address that isophoria. Same thing with multifocal contact lenses. The dual focal contact lenses, on the other hand, has not been shown to have any effect or minimal effect on binocular vision. As always, I like this slide because it sort of guides you on when to start slowing down or stopping your myopia control treatment. And we know that from the correction of myopia evaluation trial, about 48% of kids stop progressing by 15, 77% stop progressing by 18, 90% stop progressing by 21, and 96% stop progressing by 24. The reverse of that would mean 52% of children are still progressing by the time they're 15 years old. So that's not the time to stop or slow down myopia control. 23% are still progressing by the time of 18. You can start thinking about it. And if the child has not shown any progression for at least 1 year, you can start to consider slowing down or withdrawing them from myopia control. By the age of 24, only 4% of adults are still progressing. So, I mean, safe to stop. But here's the thing with contact lens options for myopia control. You can continue them up to adulthood and even to the time they're presbyopes, because for multifocal contact lenses, they are the same thing that we use for presbyopia management. Extended depth of focus contact lenses, they're the same thing we use for myopia management. Orthokeratology can also be adjusted for presbyopia management as well. So contact lens options can actually be continued straight up into adulthood without having to change anything. But obviously, if the individual decides to change or stop after a while, that's also fine. Thank you all so much for listening and joining in today. If you have questions, please leave them in the chat section and I'll take the question one after the other. That's my email if you want to reach out to me. I'll be happy to respond. And for those of you who have already sent emails, I've seen them, I'll be responding soon. I'm just putting things together and trying to arrange what goes where, and you'll get a response very soon. Thank you very much. Okay, so yeah, the recordings of I'm skipping one question, I'm going to the next. So one question, the question is where can you get the recordings? So the recordings are available on the iAfrica Media YouTube page. We've always said that. So you can go to the iAfrica YouTube page, Media YouTube page, and you would find the recordings for each day there, so you can rewatch it. We're also working on, I just mentioned this, we're working on getting this into a CPD session where individuals can rewatch the videos, take the answer the questions, and then get a CPD certification. This may vary from country to country, so you might it's going to be based on what country we get the approvals from, but we'll send more information to your emails for those of you who've registered. I see this question that says, is there a way for you to organize hands-on workshop on myopia control? Yes, we're working on that. I mean, we're already doing that for some practitioners in Nigeria who reach out to me, and we check for a schedule and then fit them in. And yeah, we're already doing that beyond just webinars. The physical training, that's something that we're already doing. And yeah, working on a certification program as well. Now, the next question is, what is the best way for contact lens wearers in dusty environments to avoid complications? Typically, we would say don't wear your contact lenses if you're in such an environment. However, a flip side of it would be switch to orthokeratology if the person is indicated for orthokeratology. That way, you just have to wear normal protection, because anyway, with your normal eyes, you're not going to be keeping it wide open if you're in a dusty environment. But with orthokeratology lenses, you're not wearing it there, but you have clear vision during that period, so you're free to do whatever it is that you need to do. The next question is, can we use AutoK alongside with low-dose atropine? Yes, you can. Although there was a study that came out, I think about a year or 2 years ago, that showed that combining orthokeratology with 0.01% atropine did not really have any synergistic effect. AutoK on its own gave better myopia control compared to the atropine used in that study. But there are other studies that have shown some synergistic effect. I have patients who are currently using orthokeratology and 0.05% atropine. So yes, you can actually do it. And theoretically, we expect that it may give better efficacy simply because the pupil might increase by about 1 to 2 mm, allowing that mid-peripheral stiffening or mid-peripheral plus that the AutoK causes to fall within the pupillary zone to allow for better peripheral hyperopic defocus correction. The next question is from an affordability perspective, if a patient cannot afford myopia control spectacles and contact lenses, are the only option a backup pair of standard vision? Would there be a major decrease in myopia control efficacy considering that there is no myopia control spectacle lens as an alternative backup? Okay, so I understand your question. So your question basically is, if we have a patient who is a good candidate, who uses contact lenses for myopia control and does not want to get another maybe expensive spectacle option for myopia control as backup, can they use single vision lenses? Yes, they can. So I have patients who are wearing multifocal contact lenses because what we regularly advise is at least they wear them at least 4 times a week. And the other days, they can actually use their single vision lenses and they still get excellent myopia control. So yes, if the patient is wearing a myopia control contact lenses, they can have backup single vision spectacle lenses. So when they take off those contact lenses at the end of the day, if it's not orthokeratology, for example, because you would not need backup spectacles if you're doing orthokeratology. But for the center distance multifocal contact lenses, once they take it off at the end of the day, yes, they can wear single vision spectacles, definitely. Another question about where you can get the recording on iAfrica Media YouTube page. These recordings are available usually the next day after the presentation. All right, so there's a very important suggestion about translating presentations into other languages to allow wider awareness. And I completely agree with that. Thank you very much for that suggestion. So this next question is, among all myopia control options, which is found to be more effective? And how do you select a patient for a particular method? And is there any age limit to which myopia control cannot be done? So to your first question, which is more effective? There is no one that I would honestly tell you is better than the other, but they all have clear-cut indications. Yes, we know some have higher efficacy than others. The contact lens options tend to have better efficacy compared to the spectacle options. The contact lens options tend to improve children's confidence compared to the spectacle options. However, the spectacle options are options that we are more familiar with, we are more used to, may have better acceptability. But there are certain indications where you're going to obviously favor a contact lens over spectacles. In a child who's more active in sports, a child who has significant anisometropia, a child who probably is tired of wearing glasses because there are children like that. A child who wants to swim and wants better vision, we'll be considering orthokeratology for such an individual. Children who are more involved in sports, contact lenses. Children who have tried other options, such as the spectacle options, maybe the pharmaceutical options with atropine, and are still progressing, you can try the contact lens options. Now, how do you select one particular method? that first of all has to depend on what is available to you. Secondly, what you're trained with. Because it makes no sense for you to just, I mean, you can't actually even do that, just prescribe orthokeratology lenses when you do not have the training for. But what's available to you, what are you trained in, and what are the parents open to accepting, and what's your comfort range like? That typically will determine what option you're going to go for, and also what the patients or the parents can actually afford in terms of myopia management. Is there any age limit to myopia control? No, there isn't. I mean, I have heard several people say this, and I'm very happy to send literature to people who think this way, is that myopia does not progress after the age of 21. That's a big lie. I mean, look in your practice and look at those myopes who are still climbing by 0.5, and by the time you look at them, maybe in 2, 3 years, they've added about 2 diopters or more. And look in your practice and look at those patients who you always look at the back of their eyes. I'm not so sure if you're seeing glaucoma or if this is just physiologic cupping. They're typically the myopic patients. And again, there is no safe amount of myopia. The only thing is for adults, we tend to want to have evidence of progression before instituting myopia management. Unlike kids, where we are proactive in starting myopia management after looking at their risk profile. For adults above the age of 24, we want documented evidence that there is change in myopia before we start to make these changes. The next question is, how then can we address the possible near work challenge with 0.05% atropine? Keep in mind that we are trying to make these patients see without spectacles. So here's what I tell you. Orthokeratology lens is actually multifocal contact lenses in a way, because it mimics a center distance multifocal contact lens. Distance portion in center and an add around it, or a plus power around it that the lens induces. So yes, there is some multifocality to orthokeratology contact lenses. Secondly, children have a very high amplitude of accommodation. So again, most times when we use 0.05% atropine, I don't see children complaining about those things, but I'm usually proactive to prescribing bifocal spectacles or progressive addition spectacles. For my patients who are currently using low-dose atropine and orthokeratology, I don't get complaints about issues relating to near vision. Possibly because, again, there is some multifocality to orthokeratology because of the mid-peripheral steepening and the plus power that it induces. Secondly, it might be in terms of the optics and how, again, aberration is quite complicated, to be honest, but there might be some protective effects. And also for myopia control, like I said, we tend to fit a smaller optic zone diameter for orthokeratology lenses for myopia control. So some of that plus power is getting close to the pupil, so they typically would not notice that. I don't get any complaints for it at all. But if there is somebody who happens to have such complaints, maybe the kids can pop in some low power progressive addition lenses just for reading, but I've never had to do anything like that before. So I see someone asking about bifocal lenses. How do you determine the add power? I mean, I think we talked about this severally. If you're looking at a child with a high lag of accommodation, typically we are a lag above 1 diopter. The recommendation is to remove 0.5 from that lag to get the add power. But most times in clinical practice, we do not have, it's difficult to get sometimes add powers below +1 diopter. But that takes you back to what has been studied in most clinical trials, which is an add power of +2. So it's fine to just hit the kid with a solid add power of 2. For multifocal contact lenses, if that first answer was for spectacles, for multifocal contact lenses, we would recommend a high add, because from the blink studies and even in the discontinuation of the center distance multifocal contact lenses in the blink study, what we saw was that children in the high add group, that's the add that had +2.5 diopters, tended to have much better myopia control compared to the low add group or the control group that was single vision contact lenses. I'd also say this, that I noticed that For multifocal contact lens, as with any other form of multifocal contact lens, whether it's center distance or center near, but for multifocal contact lenses, you need to keep in mind that there is a neuroadaptation period, typically between 2 to 6 weeks. So yeah, the child might sit on your chair, might read 20/20, but still tell you, this looks a bit off. And that's because multifocal contact lenses uses that simultaneous vision principle. You have the distance power at the center, the add power around it. So it causes a decrease in contrast sensitivity a little bit, which takes time to adapt to. So to aid the adaptation, sometimes clinicians add a minus 0.25 over the correction to improve this. So let's say I was going to prescribe the center distance multifocal contact lens to a child. I would, and let's say the child was -4. So I'm supposed to prescribe, let's say -4 at 2.5, for example. Or if it was a -6, again, you'd have to do your vertex correction and determine what that power would be, somewhere around -5.5, and then an add of 2.5. We typically would add a bit more, 0.25. So instead of -4, I probably prescribe -4.25. Instead of the -550, I prescribe -575 to help with that contrast sensitivity. But again, sometimes this is not required. Most times, between 2 to 6 weeks, the individual or the child adapts to the center distance multifocal contact lens, and they're good to go. Kids are usually very forgiving when it comes to issues like this. I don't see any other questions, so I think we've answered those. Again, the recordings for these will be available on the iAfrica Media YouTube page. We're very grateful to our sponsors, BioLens Incorporated and the Lens Ophthalmics. So basically, BioLens would like to announce that for practitioners who are interested in orthokeratology fitting and being trained in orthokeratology lenses, there's going to be a training. There's a fee for the training, which is $200, reduced compared to the typical fee that's charged for orthokeratology training. The individual will be getting a certificate certifying you in orthokeratology lens fitting. And the first pair of lenses that you order for your myopia control patients will be sent to you free of cost once you've gone through the training for orthokeratology. So if you're interested, you just leave an email. Just send me an email. And once the program coordination is done, you'd receive an email from iAfrica Media letting you know how you can register. But you have to either have a corneal topographer or have access to a corneal topographer, maybe in a place where you can refer for corneal topography to be able to take advantage of the training. Or if you just want to be able to learn orthokeratology, you could also do that as well. So you can just send me an email and then we'll be happy to set up a time for that training for you. Yeah, so thank you all. Thank you everyone for joining in. And I mean, for those of you who've sent me emails about being interested in research, those of you who've sent emails about wanting to have hands-on training for orthokeratology, or also myopia control in general, I've seen those emails, would reach out to you and tell you the details of how we intend to have those trainings and organize those trainings set by set. And sometime this year, we probably will be looking at doing an interstate training. For those of you in Ghana, there'll also be some physical training, hopefully at the conference, hopefully soon. Again, if you're interested in orthokeratology, the offer from BioLens is we train you on also for multifocal contact lenses as well. Train you on fitting these multifocal lenses, center distance multifocal contact lenses for myopia management, and also train you and certify you to fit orthokeratology lenses from BioLens. There's a fee of $200. iAfrica Media will reach out to you with details, but you have to send me an email so the scheduling can be arranged for better coordination. I'd like to say a very big thank you for attending the webinar. Thank you for the questions, which have been very impactful. Thank you for contributions. Thank you to all the speakers who've been here, from Professor Olga, Colvin, Levi, Bernardine, Godwin, Swapnil, We're very grateful. And for all of you who've attended throughout this week, we're very grateful. Thank you, BioLens, for sponsoring this event. And thanks to the Lens Ophthalmics as well for sponsoring the event and creating a platform where we can reach the rest of Africa. I'll just end this by challenging every one of us to get involved in some way in terms of myopia management. Start with what you have, better yourself, offer better care to your patients, and you'll be happy for it. For those of you interested in research, start in the way you can, collaborate, as we've always said, but get involved and do something. Elevate yourself clinically and move beyond the basics that you already do, because I mean, with the wave of technology coming in, you don't want to be left behind in terms of specialty eye care as the world evolves. Thank you once again, and good night, everyone.